So we're going back to lectures. So Dr. Miri Sklair-Levy is not the first time in our conference. I met her, she was in class. And then she came to Eliconnet's department. And so she's, as everybody knows in Israel, she's an amazing radiologist. She's taking care of mammography, senology. She has a very nice department and opened a research MR and is doing a lot of things and teaching a lot. And she's an amazing lecturer, so I'm so happy she accepted to be with us today. Thank you so much.
Thank you very much for the introduction and for the invitation. And I was asked to try to introduce you the new strategies in the diagnosis of breast cancer, or when and why we are using other modalities than just mammography and ultrasound in the diagnosis of breast cancer in the year 2016. So the purpose of my talk, and I will try to introduce you with the screening modalities that we are using and the diagnostic imaging in breast cancer diagnosis, and the reason why we are using each modality. And I will also, at the end, will talk briefly about image-guided diagnosis, which has a major role in the diagnosis of breast cancer, and it is done by the breast imaging radiologist. So I will try, to do it interactive. So please feel free, to answer. So this is, for example, I don't need so much dark. We can have more light. עכשיו קצת יותר אור. עכשיו קצת יופי. זה בסדר. Okay. So this is a 60-year-old woman that came for screening mammography, and this is her mammogram. So do you see anything? Yes. What side and where? Left, where? Okay, so left, maybe here, some asymmetric density, okay, small but asymmetric density. Okay, so first when we are looking at mammography, we have to give the BI-RADS, the interpretation of breast imaging, mammography, ultrasound, and MRI, is according to the breast imaging reporting data system lexicon, which is the BI-RADS, and it goes from 0 to 6. So what is the BI-RADS of the mammography? 0. Meaning, what do you want next? Sonography. But before the sonography, what was the breast density of this woman? I just go back. B. Okay, so it's there are scattered fibroglandular tissue, but not very dense. Okay. And the findings we saw, the left central irregular lesion, and BI-RADS 0, because we need another study. And our next step is ultrasound. And on ultrasound, we see this hypoechoic irregular lesion, BI-RADS, or B. Okay. So it's a BI-RADS 4. We divide BI-RADS 4 to A, B, C, where A is the probability of cancer is below 25%. B is 25, 50, if I don't remember, I might not be accurate, and C is above. I must say that I don't use so much the division A to C. Why to use it? Because BI-RADS 4, the chance of cancer is from 3 to more than 93%, so it's a wide range. That's why it was divided. But from my daily practice, when sometimes, for example, this lesion I can give a 4A and it comes back a cancer, and then the clinician asks, but you thought it's most probably benign, so why is it compatible with a malignant lesion, or the opposite? I might give it a 5 and it comes back benign. Oh, but you thought it's a cancer, so how come it is a benign lesion? So from my practice, I prefer, do a biopsy. Biopsy 4, do a biopsy. I don't have to guess because I'm going to do the diagnostic procedure. So I just say 4, but I understand it's more personal attitude. So it's a biopsy 4. So what we are going to do? Biopsy. And the biopsy is image guided and ultrasound guided, which is the most convenient way to do a biopsy, and it is usually core needle biopsy. We are using a 14-gauge needle, and the diagnosis was invasive ductal carcinoma. Okay. So, are we going to do anything else? Okay, so when there is a diagnosis of breast cancer, we have to look at the axilla. Okay, so we have to look at the axilla, so we are looking on ultrasound, and in ultrasound we see this lymph node, which is normal appearing lymph node, it's not enlarged, and the cortex is regular, not thickened, so it's a normal appearing lymph node, and we don't have to do a biopsy from this lymph node. And the surgical management of this lymph, or of the axilla, will be sent in a lymph node biopsy. Okay. What else? In this case, the woman had also an MRI for the evaluation of extent of disease, and we can see the same small lesion on the left breast, central, nothing, no other lesions, not on the right and not on the left, so it's a unifocal disease. And the woman can undergo a breast-conserving surgery, lumpectomy, following localization of the needle, of the lesion. It was not palpable, fine needle localization, and since it was seen on ultrasound, it was ultrasound-guided fine needle localization, and a lumpectomy, breast-conserving surgery, and this is the specimen radiograph, and it goes to pathology, and the pathology was invasive ductal carcinoma, single lesion. So it is a simple case, screening mammography, which found a small lesion and was diagnosed. So this is our common practice, and we wish that all the cases will be so. But let's look at a 74-year-old woman that presented with a lump in her left breast. What study are we going to do? Mammo? Let's do a mammo. Okay, so she had a mammo. What is the biology of this mammo? What is your biology of this mammo? Just, it's feel free. 0. Meaning you don't see anything, but before, okay, but I think it is important in this case to comment on the breast density, which is, for a 74-year-old woman, what is the breast density? It's a very dense breast, and we all were taught that with the age, since 74, the breast should be more fatty, but we see that even at the age of 74, the breast can be very dense, and it's not unique. From our practice and from the literature, we are speaking about more than 50% of women above the age of 50, 60 have a dense breast, so we should be aware of the breast density. The main reason it is important to comment on the breast density or to look at the breast density is that we know that we can miss a lesion. The sensitivity of a woman with a dense breast is less than 50%. So the woman feels something, we don't see anything, and we need to do another study. So it is a BioRad 0, and we did an ultrasound. And on ultrasound, we see this hypoechoic, round, taller than wide lesion by right. Okay. But someone can say, oh, maybe it's a cystic lesion, some posterior enhancement, but it's more taller than wider, and I agree it's a BioRad 4, and she had a biopsy. And on biopsy, it was invasive ductal carcinoma. Okay. What are we going to do next? Do we have to do anything else, or she can go to lumpectomy? Axilla. Axilla was normal. Surgery? Come on. In my lecture, we did a lot about MRI, so I think that before treatment, although she is 74, but she is 74 in a good, she is a healthy woman, I think Since the mammography is very dense and the lesion was seen only on ultrasound, I think it is reasonable to do an MRI for the preoperative evaluation. And this is their MRI. And on MRI, this is the right side and this is the left side, and this is the CAD image. I'll talk about it in a minute. And on the left, we see this round lesion, which is compatible with the known tumor. However, we see a kind of linear enhancement anterior to the lesion and exterior, and we call it non-mass-like enhancement. On MRI, we have a mass and a non-mass-like enhancement. Okay, so what is the bi-rads we know? The bi-rads now is 6, because it's a known cancer. And what are we going to do now? A biopsy. How are we going to do the biopsy? MRI. Okay, but before, we can also try to see it on ultrasound or second group mammography to see whether there are microcalcifications, and let's see. So, mammography was, we didn't see a lesion, and on ultrasound we saw this small lesion, and on MRI we see this mass and a non-mass-like enhancement, which is much more extensive than the known 8mm carcinoma. So, a few words about the MRI interpretation. So again, it is in the lexicon. And the lexicon today is on the web, so it's easy to use it. MRIs is the examination with the highest sensitivity for the detection of breast cancer, mainly invasive breast cancer due to the administration of the IV contrast. And we are looking for the angiogenesis, and we are looking for the morphology and for the enhancement of the lesions. And again, here we are looking for the morphology and for the enhancement, which is called the kinetics. And when we are looking at the kinetics, there are 3 types of curves. The first one is the red one with the rapid enhancement and rapid washout. Since in the cancer there are more blood vessels, however those blood vessels are irregular and they are more leaky, so they cause to the more rapid enhancement, however also with the washout. And this type of curve is more typical for the breast carcinoma. There is the plateau, which can be in benign and malignant lesions, and the progressive type, which is more in benign lesions. However, and we'll see it also later, in the cancer we can see a mixture of the enhancement. The lesion is not homogeneous, and I'll show it to you later. So when we are looking at the MRI, there are mass and non-mass enhancement, and for the masses, according to the lexicon, and also something that is only we can see on MRI is the focus, which is a small lesion, smaller than 0.5 centimeter. And for the mass, we describe them whether they are round, oval, and the margins. And the more the mass is irregular, the more it is suspicious for malignancy. And for the non-mass enhancement, we describe whether it is linear, ductal, segmental, and regional, and this is how it looks on MRI. Okay? So this woman had a mass and a non-mass enhancement on MRI, which was much more extensive on the MRI compared to the ultrasound. And the importance is, if she had only the 8mm mass on ultrasound, we can do breast conserving surgery. However, with the 9 centimeter mass, there is the issue of what type of surgery she is going to have. And since we are accused, one of the accusations is MRI is too sensitive, you're causing us more mastectomies. So in my eyes, it is very typical of carcinoma. However, we should prove it, and how we are going to do the biopsy. So we are going first to do a second look mammography. I didn't see microcalcifications. However, on the second look ultrasound, I saw this irregular lesion behind the nipple, and she had a biopsy, and it came back as a DCIS. So now we have an invasive ductal carcinoma and a DCIS in a distance of 9 centimeters. Then there is an issue that we are discussing together with the surgeons, what type of surgery. It is possible, depending on the size of the breast, to do a bracketing of the tumor with a needle localization anterior and posterior to define the entire extent, and then to have a breast cervix surgery. However, it is also possible that she will undergo mastectomy. It is not necessary in her case to have mastectomy. This is the process that this woman, the discussion in this woman. Okay? And again, in this case, 74-year-old woman, very dense breast, the limitations of mammography in dense breast we do not see. So if you do not see in a woman that complains of a palpable lesion, do another study. The first study is usually ultrasound, and in a dense breast, it is reasonable to do the pre-op evaluation with MRI, and it is known from the literature that we can see additional lesions in up to almost 30% of the woman. So those are the limitations of mammography in dense breast. Sensitivity might be very low, up to 30%, and again, as I said, the breast density is not uncommon. It is common even in women that are above 50. So we should be aware. And I think that you know, there are 4 degrees of the breast density according to the ACR breast imaging reporting data system, and it was changed from 1, 2, 3, 4 to A, B, C, D, not to confuse it with the final report of the breast imaging reporting data system. So we call it 1 is A, 2 is B, 3 is C, and 4 is D. And the importance is, in a woman with a dense breast, we can miss on mammography findings. Okay, so let's see another woman, a 52-year-old woman. She is postmenopausal, and she came for screening mammography, and she had her uterus removed at the age of 45, and she decided to take HRT, and she's on HRT, and this is her mammogram. But density C, and what do you think? Do you see there anything? Distortion where? What side? On the left. Yeah, here there might be some distortion that we don't see on the right. Okay. And as you see, we have contrast-enhanced spectral mammography or dual energy mammography, and this is the study that she had. So this is her mammography, which we call a low energy mammography, and we immediately see the high energy, the contrast-enhanced mammography. And here we can see very clearly that she doesn't have anything on the right side, but on the left we can see those 3 lesions posterior to the nipple. Okay? So now it is around 4. We need to do a biopsy. Okay? So we said before the contrast images, it's about around 0. We have to do another evaluation. We can do spot images, we can do compression images, but I'm not sure that we'll have the answer with the mammography. And I think that the contrast mammography gives us the answer. And in addition, we also compared it to a previous mammogram 2 years ago, and we see that this area is more prominent compared to the study that she had 2 years ago. Okay. And now the BioRad is BioRad 4, and how are we going to proceed? Ultrasound. So, just before the ultrasound, a few words on contrast mammography. Contrast mammography is a dual energy technique. It is used, we're using the same digital mammography system, however with modification in software and hardware. And the system that we have is the GE system, which was the first in the market. And we inject iodine, non-ionic iodine, the same amount and the same rate with a power injector as in the CT. And basically we see 2 images. The low energy image is the analog of the digital conventional mammo image, and the high energy image is sensitive for the iodine, and there we see, if there is enhancement of lesions, we see those lesions. We start to image 2 minutes after the injection, and there is always the issue of the radiation, so the radiation is 20% above. However, from our daily practice, unless we had the contrast mammo, we will add sport, lateral, many views which are comparable to the addition of this 20% of radiation. So it spares us the additional views that we are using when we are doing only digital mammography. And this is just another case, again, a woman that already had breast cancer, she had a surgery, here we can see the scar, and she came with a palpable lesion in her left breast. Maybe there is a density here, but those are the contrast high energy images, and we can see that she has many lesions which were proved to be cancer. So those are the images. So we said it's a bi-rad, we did an ultrasound, and an ultrasound we saw those 2 lesions. On the mammography, on the contrast images, we see 3 lesions, however they are very adjacent one to another, so in an ultrasound we saw those 2 lesions, and our next step is, of course, calling the biopsy, and it came back as invasive ductal carcinoma. Next. Yes. Surgery, lumpectomy, mastectomy. Okay. Why do you say mastectomy? No, in her case, it's she is a screening. She comes from screening. Multifocal. Okay, but multifocal is when we have more than one lesion, but in the same quadrant. That's what she has. And the total distance of all those lesions is 3 centimeters, while each lesion is 1 centimeter. And I think it's possible to do a lumpectomy, but again, to do a localization of each one of the lesions, and then maybe to do a central lumpectomy. Okay, but before, although we had the contrast mammo, we still did an MRI, and on MRI, we saw, again, the same 3 lesions, okay? And here we can see also the time enhancement curves, but also again, look, the lesions are very typical from carcinoma. There is more red than blue. However, the enhancement or the color inside the lesions is heterogeneous. And we know today that there is a heterogeneity in breast cancer, in the lesions. And the meaning is the more heterogeneous the tumor, the more it is violent. So today we have more and more literature about the significance or the importance of the heterogeneity in breast cancer. I think in every cancer, but I'm speaking about breast cancer. And another important thing is we see a small foci of enhancement in both breasts, and this is what we call a parenchymal, background parenchymal enhancement. And in breast MRI, in addition to the density that we see on mammography, we see the enhancement of the parenchyma of the normal breast tissue. It is common to see it in young women, premenopausal, or in women that are taking HRT, and this is the enhancement of the breast tissue. And again, today we have more and more literature that the more there is the background parenchymal enhancement, it is more associated with the chance to develop breast cancer. And I think that the pathophysiology is the activity of the breast tissue, which might, the activity which means that there are more cell division, more mutation, chunks of mutation, and then the development of a breast cancer. And in this case, we see this background parenchymal enhancement. And in addition, as the breast density on mammography, this background parenchymal enhancement, I cannot tell whether this small focus is a background parenchymal enhancement or a small lesion, so it limits our sensitivity in the interpretation or in the diagnosis of small lesions. So on MRI, we have 2 things. We have the density and we have the background parenchymal enhancement, which we commonly only. Okay, and here we can see very nicely correlation between the contrast mammography image, the 3 lesions, and those 3 lesions on MRI. They are quite comparable. So in summary, she came for a screening mammography. She did the contrast mammo, which gave us the diagnosis immediately, and we are looking at the images. We are at the room while the technicians are doing the image. We see the low energy, the conventional mammo, and immediately after the contrast mammo, and we see the lesions. And we have the diagnosis very quickly. So a few words on what are the developments in mammography. In the mammography, since, as you have seen, dense breast mammography is very limited. So that's why in recent years there are so the development of the contrast mammography, and the other imaging modality in the mammography field is the tomosynthesis. And tomosynthesis is the 3D mammography, and it's a technique, I think, that it was used for tomosynthesis to look for renal stones. So basically it's the same technology. The image or the image acquisition is the same as the mammography machine. However, the arm is moving and is taking serial images and reconstructs them. And there are different vendors and different techniques, but basically we have, instead of 4 images, we have from 80 to more slices. And the advantage is that we can ignore, or we can solve the problem of the superposition of the breast density. This is, for example, the graphical image. On 2D conventional digital mammography, there is the superposition of this cancer with the other lesions, and we can miss it. However, when we are doing the tomosynthesis, we see it from different angles, and the chance that we miss it is reduced, or the chance that we will find the cancer is better. This is how it looks. Those are the slices, and here, for example, there is this cancer that we see only on this slice and on this slice. However, we don't see it on the other slices. And today there is an extensive literature on tomosynthesis. This is, for example, a study that was published recently on a large, almost 500,000 images that compared digital mammography to tomo. And it has been shown that there is an improvement in the cancer detection, however, not very dramatic. It added 1.2 additional cancer to 1,000 women, and the advantage is the elimination of the overlapping tissue. And it seems that tomosynthesis is a better imaging technique than mammography. Is it going to replace mammography for the screening? It seems that it is going, but the disadvantages are more radiation, longer time of reading. Instead of 4 images, we have to read 8 images. So there is a continuous debate, but there is more and more data that says that no doubt that tomosynthesis is a better imaging than mammography only. Okay. Let's look at another patient. She's a 48-year-old woman, and she presented with a lump in her right breast. What are we going to do? Mammography. So this is her mammography by odds. I think it's a normal mammography. We don't see anything, but she presents with a palpable lump, so I think it will be a 0. Density is very dense, C or D. And our next study is going to be ultrasound by odds. Two? Cyst? Okay, that's what I thought. Because you're right, it's an apoechoic, there is a posterior enhancement, it's quite regular. I thought it's a cyst. Maybe it's a Bioroids 3 and let's do a short-term follow-up. That's what I did, but I said, come back in 2 months. 2 months because I was kind of worried. Or I said, I need help. The next time that she came, I said, it's a little bit bigger, I need help. So what is the help that we have today in ultrasound breast imaging? It is elastography. So when I see this kind of a lesion and I have a doubt whether it is a cyst or a solid lesion, we put elastography, and in elastography, it is not a cyst. It's a solid lesion, and it's a stiff lesion. There is I'll show you in a minute, there are 2 kinds of elastography, but if on elastography the lesion becomes larger, it's not a cyst, it's more suspicious for a malignant lesion. And it was a bilateral form with a biopsy, and it came back invasive ductal carcinoma. Okay? So our next step, you know me, I do MRI. And this is her MRI. I had to switch the images, okay? And we can see this lesion, central lesion, has central necrosis. This might be the explanation for their kind of cystic appearance. And we can see the enhancement. We can see that it has the typical rapid wash in and wash out. However, again, it is heterogeneous. We are using today in every breast MRI the CAD, the computer-assisted detection software. There are different vendors, and it gives us those maps, okay? We can also have the dimensions of the tumor and the shape of the tumor, okay? So this is the MRI compatible with the lesion that we saw, and she can now have treatment. Lumpectomy. And she had a lumpectomy. It was a unifocal lesion. She had a lumpectomy. The axilla was normal, so she had a sentinel lymph node biopsy, which was normal. However, when asking her, she said, I have maybe a cousin and maybe some relatives. So she had a genetic testing, and she was found to be a BRCA1. BRCA patients are more prone, or they develop breast cancer at a younger age. They have between 60 to 85% who develop breast cancer during their lifetime. And they have a higher chance to recurrence. So she decided 6 months later to undergo bilateral breast mastectomy and silicone reconstruction together with bilateral salpingo-oophorectomy, which are also protective against the development of breast cancer. Okay? So, a few words on the advances in the ultrasound, breast ultrasound. So, I showed you the elastography, which you use very frequently. In elastography, there are basically 2 softwares. The first one is the static that I showed you, and it's a qualitative measurement, although today there is the addition of the RFI, which is a quantitative. And the second is the shear wave elastography, which is a quantitative measurement of the elasticity of the lesion. And we know that breast carcinoma is more stiff, is more hard, and this is the information that elastography gives us. In addition, on elastography, cysts have a typical appearance, and sometimes, as in this example, there are some internal echoes and we are not sure whether it is a cyst, so we put the elastography button and there is the typical bull's-eye appearance, or the 3 layers. This is the artifact, the typical artifact in the static elastography, and when I see it, I know it is a cyst and not the cancer that I missed the first time. So we use it very frequently. It's simple, it works very fast. And in contrast to breast cancer, when we see this lesion and we are not sure whether it is a solid or a cystic lesion, put the elastography, and we see that in elastography it's more stiff and it is larger, compatible with breast cancer, and we do the biopsy. On the other technique, the shear wave elastography, there is also a color map. However, it gives us also value in kilopascal. Again, there is an extensive literature with different sensitivities and specificity where you put the bar of the kilopascal, of the stiffness, but when the lesions are blue, which means soft, and the kilopascal is below 30, most probably a benign lesion. In this case, it was a fibroadenoma. In contrast, for example, to this hypoechoic lesion, which is also quite elliptical, maybe here some irregularity, but when we put the elasto image, it has values that are higher, very high, more than 100, highly suspicious for carcinoma, and it was indeed a breast cancer. So we use, for every lesion that we see on breast ultrasound, we just press the button of the elasticity, and it helps us to differentiate between whether to do a biopsy or not to do a biopsy, whether it is a cyst or a solid lesion. It seems that we are going to use elastography to characterize solid lesions, and the main purpose is to see if we think it's a bilateral 3 lesion, to be sure it is a bilateral 3 lesion and not to upgrade it to a bilateral 4 lesion, or the opposite, if we think it's a bilateral 4 lesion, however, the elastography image is a benign one, we can downgrade it to a bilateral 3, and in that way to save benign biopsies. We are doing around 60% of our biopsies are benign biopsies, so if we can do less biopsies of benign lesions, this might be one of the ways. Another development in ultrasound breast imaging is the automated breast volumetric scale, which is an ultrasound. Since we are doing breast ultrasound very frequently in women with dense breast, for example, in our unit, we are doing almost 60–70% of the women are doing breast ultrasound in addition to the mammography due to the dense breast, so it is very intense, and the physicians are doing our unit ultrasound. In some places those are technicians, but in order to overcome the load, an automatic breast ultrasound was developed. And the advantage is that it is performed by a technician. If breast ultrasound is very operator dependent, so in this case, the study is not an operator dependent, it is a quick study. All the images are stored in the computer and can be viewed later. It is possible to do a reconstruction. So, no doubt that in the States, for example, those systems are replacing the technicians. Unfortunately, in Israel, we are not using it so much. There are advantages of the system. However, for example, from our practice, when a doctor is doing the ultrasound, it is very difficult for him to change for an automatic ultrasound because we do see artifacts. So I hope that the technology will improve, and I think there is a place for this technology, and it has been proved that it has the ability to increase the number of the cancers detected from only 3 per 1,000 by mammography alone, almost to double it when we also add the automated breast volumetric scan. This is how it looks. We have the axial normal image. Here we see the irregular mass. We see the 90 degrees image, and we see the coronal reconstruction. And here we can see a 3D coronal image with speculation, very similar to the surgical view. Okay. Now let's see. I think it's the last case. 45-year-old woman, she has a family history, and that's why she is high risk. We'll start with, so she had the mammography, and again, the density is, I think, C or D. And the birods, if you look carefully, there is this small lesion at the upper outer area. So I think it's a birod 0. Okay. And our next study is going to be and on ultrasound, we saw this small, irregular 0.4 centimeter lesion. It's a birod. And she had a biopsy. And on biopsy, we saw this is the true-cut cone with a biopsy. And there is fibrosis with irregular glands. And the pathologist said it's compatible with a radial scar. Radial scar is not a scar. The name is, since the pathologist see this fibrosis, which looks like a scar, but it's not a scar. It is a high-risk lesion, which is associated in about 20% might be associated with tubular carcinoma, and therefore there is an indication for an excisional biopsy, excisional surgical biopsy. Okay. However, I would like to show you an alternative to an excisional surgical biopsy. So we are very common or doing image-guided corneal biopsies using a 14-gauge or the vacuum-assisted breast biopsies using ultrasound guidance or mammography guidance. However, this is a new technology. I think it is already more than 5 years that it has been used. The breast lesion excision system. It is a needle that is using radio frequency to excise completely the entire lesion using image guidance. And I'll show you. So that's what we did. This was the lesion, and we took it out. Okay. I'll just show you how it looks. Right. This is the needle. It opens. There are 4 fronts that encase the lesion, and you take it out. It takes 10 seconds, and I'll show you. This is how we are doing it. This is ultrasound guidance. And I'll show you the comparison between this is a vacuum-assisted biopsy with a 9-gauge lesion. And in this technique, small pieces of breast are accumulated in this small container. I'll show you. Okay, those are the pieces in a vacuum-assisted biopsy. Okay. And in the bless or the intact system, again, ultrasound guided, use the needle. It takes 10 seconds. The basket is open. It encapsulates the lesion in 10 seconds, and the procedure is done. And it is done under local anesthesia. Contraindications is if the woman has a pacemaker. This is the needle. And with the basket, and the lesion is a complete lesion, like an excisional biopsy, in 10 seconds under local anesthesia. So we decided that's what we did, and we took the entire lesion. And if you compare the specimen, the pathological specimen here, compared to this, it's a complete lesion. And this is the pathology image of the intact. And we can see the classical appearance of the radial scar, central fibroelastic, and the radiating irregular glands like a flower. So it was a definitive diagnosis of radial scar, no additional or adjacent cancer. And she is in a follow-up of 2 years, no recurrence, and she is healthy. Okay, just the concordance, again, very important to compare. This is the mammographic image, irregular small lesion, the ultrasound image, and the pathology, and we can see very nice the concordance and the final diagnosis of the radial scar. And the advantages are that it's an intact specimen, And for the pathologist, it was much easier to make the diagnosis because the architecture is preserved. It's one specimen and a good correlation with the imaging and the pathology. There are different sizes. Today, the maximum size is 2 centimeters, and it's going to be 3 centimeters. Okay. I would like to show you briefly our intervention, or as you see, most of the diagnosis today is image-guided diagnosis of breast lesions. Before the 90s, the diagnosis of breast pathology was mainly surgical diagnosis, and it yielded a good specimen. However, it is a surgery, and so it has converted to image-guided diagnosis, either stereotactic, ultrasound guidance, or MR guidance. And the imaging modality that we use is the one that we see the lesion. The lesion is best seen. This is the stereotactic machine, and this is the MRI guidance. In addition, as you saw in the cases, we try, since we are doing the screening, most of our breast cancers are non-palpable, and in order to perform a lumpectomy or breast conserving surgery, we are doing a needle localization. And again, if we saw it on the ultrasound, so the needle localization of the lesion is ultrasound guided, or if we saw it on mammography, it's mammography guided. And in this way, the woman is at the OR, the surgeon is taking the entire lesion with the hook wire, and there is the specimen radiograph to ensure that the lesion is out, and only after the validation of the excision of the lesion, it goes to the pathology for the final definition. Another intervention that we are doing are the clip mark. The beginning was in women with locally advanced breast cancer. Today, some of the women, according to different protocols, undergo chemotherapy before surgery. In many cases, the tumor disappears. So before the treatment, we put in the tumor what we call a clip mark, which is a small metal. It comes in different shapes, vendors. We put it in the tumor, and in many cases, the tumor disappears completely. It is very important to put this clip mark. At the end of the treatment, this area should be excised. If we will not put the clip mark, the surgeon will not know where to do the surgery. So we do those clip marks, put those clip marks. In addition, we sometimes do a biopsy for very small lesions that might disappear after the biopsy. It is important when we think about it to leave a clip mark in case it's going to be a breast cancer, that we will know where was the lesion. So just to let you know, clip marks, most of them are MRI compatible, they are not moving, the woman doesn't feel them, but they are very important for the planning of the treatment or for the follow-up of the patients. So, in summary, just showing the breast imaging, and we divided for the screening of asymptomatic patients and for the diagnostic workup. About the screening, there is a continuous debate when to start, how often, and the guidelines are changing. In Israel, for example, it is from the age of 50 every 2 years up to the age of 74. The ACR guidelines were from the age of 40 every 2 to 1 year, but it has been changed from the age of, by the American Cancer Association, from the age of 45 every 2 years, and between 40 and 45 it has to be discussed with the doctor. This is, for example, a slide to show you that it is not that breast mammography does not detect breast cancer even at the age of 40 to 50 is, but the difference is in the amount of examination or mammography studies that we have to do in order to diagnose the breast cancer. So I think that the debate will not stop, but the policy will change with time. And for the diagnostic images, I'll show you the cases that we are using not only mammography but a multimodality. However, what we are doing today, we are dividing our images to the anatomic imaging modality, which is mammography and ultrasound. For example, if you take, it is an analog like if you do a CT of the abdomen, of the liver without the contrast. So this is the mammography ultrasound. Either you see a lesion or you don't see, but it is not a very diagnostic study. When there is a lesion, you are going to see it, but we know that we are going to miss lesions. And our hope is to use a more metabolic or functional imaging. And the functional imaging studies I showed you is the contrast mammo, is the MRI. Whenever we inject contrast, we see the morphology, but we also see the vascular supply of the lesions and the sensitivity of the studies of the detection of the breast cancer is increased. So people ask me, okay, so are we in the era of screening MRI? And there is always the issue of the price, of the availability of the time. Christian Kuhl, she is home I think now often. She is one of the leading breast radiologists in breast and breast MRI. And this is a study that she showed it is possible to do a short MRI. Here she did a very short MRI scan, only the dynamic, one before and one after. And it was a 3-minute scan. She showed that there were additional 11 breast cancers that were not seen by mammography. Or if you look at the numbers, mammography detects 3 to 4 cancers per 1,000. MRI detects 18. So the numbers are not comparable. So it's something that we have to think about. And maybe the future will be a more functional metabolic imaging, either contrast mammography, either MRI, to improve our sensitivity in the detection of breast cancer. Maybe it will be in your era. So just to sum it up, our anatomic imaging are the mammo, the tomosynthesis, the ultrasound, with a limited sensitivity as I showed. And we have to be aware of the other option of the metabolic and functional imaging, which is the contrast, the MRI, with higher sensitivity. And I hope that I have shown you that it's not only mammography breast imaging, we have more modalities, more specific, more sensitive modalities that we can use. Thank you.
Thank you so much, Miri. It was so important to have your expertise about, because it looks like a whole world is developing in front of us. Wow. And as a woman, I feel concerned, I'm sorry.